warm good afternoon to respected dignitaries and the delegates. I welcome you all to my presentation on sequelae of vitamin A deficiency, a case report. I am a postgraduate resident from Rio GMCH. So on introduction, vitamin A deficiency is an important cause of nutritional blindness in young children and causes more than 250,000 children to go blind in Asia each year, of which 52,500 cases per year are from India. Vitamin A deficiency also leads to retarded growth and development, decreased immunity, and increased child morbidity and mortality. Although on the national immunization schedule, vitamin A supplementation is mandatory, around 1/3 of children are not receiving the required dose. So a 10-year-old female presented to us with gradual, progressive diminution of vision with whitish discoloration of the cornea, both eyes, since the last 2 years, which gradually she presented with pain since the last 2 weeks of the left eye. There was no history of redness, discharge, trauma, or any ocular illness in the past. She is a patient who suffers from chronic diarrhea and was treated by a local herb practitioner. There is no history of similar illness in the family. Her birth and developmental history were uneventful. She was exclusively breastfed up to the age of 2 months and has incomplete immunization. Her family belongs to lower socioeconomic strata. So on local examination, the positive findings were adherent leukomatous opacity centrally covering the pupillary area of the right eye, and in the left eye there was increased interpalpebral aperture and a corneal scar with scleromalacia and impending staphyloma superiorly with superficial vascularization. In the iris, we see an adherent iris tissue to the cornea at 3 o'clock position. The pupil was irregular and was of around size 3 millimeter. Only direct light reflex was positive. The visual acuity of the right eye was hand movement, which did not improve with pinhole or best corrected visual acuity. And in the left eye, it was PL negative, and extraocular movement was diminished in all directions and was painful. And the intraocular tension of the left eye was digitally hard. Rest of the anterior segment appeared to be normal. Ultra USG B scan of the right eye was within normal limits, and the left eye, in the left eye it was avoided as the patient was in pain, and also there was impending staphyloma. On general examination, the child was alert, awake, comfortable, and assuming a decubitus of choice. She was thin-built and cachectic. The vitals were within normal limit. On anthropometry examination, her height was around 120 centimeter, weight was around 24 kg, which was, both of them were below -3 standard deviation, and her BMI was around 16.7, which is also less than -3 standard deviation. On general examination, we could find pallor. The oral cavity, tongue was pale and smooth. Angular stomatitis and cheilitis was present. Teeth and gums were unhealthy. The skin and appendages, it was dry, lustreless, and scaly skin. Limbs, there was mild muscle wasting present. On routine hematological examination, routine blood was within normal limit, but her hemoglobin level was 5.2 gram per deciliter. Her iron profile was low, and peripheral blood smear showed hypochromic hypovolemic anemia, and her serum retinol levels were 0.45 micromoles per liter. So we came to the provisional diagnosis of grade X3 xerophthalmia, grade X3A on the right eye, and grade XS with scleromalacia and severe acute malnutrition of the left eye. Management was started with vitamin A capsule, which is as recommended by the Government of India, WHO protocol, 2 lakh international units on day 1, then followed by 2 lakh international units on day 2, followed by 2 lakh international units on day 14. Eye drop hydroxypropyl methylcellulose of 0.7% was started for 1 drop 4 times daily, and a multivitamin dose was given. So our patient presented with painful blind eye with impending staphyloma, due to which enucleation of the left eye was done after proper consent, so that further progression of the disease could not occur and to maintain cosmesis. Her right eye is planned for penetrating keratoplasty and registered for the same. She was referred to the pediatrics department for further management and was started on fortified food. Patient is on follow-up. Coming to discussion, so we report a case of late-stage xerophthalmia with severe acute malnutrition. Diagnosis of vitamin A deficiency in a tertiary care hospital at such a late stage is very rare and unwanted. Our patient had not been diagnosed anywhere, although she had been presenting since the last 2 years, and leaving her with permanent visual deficits. So at-risk children, such as those belonging to lower socioeconomic background, decreased breastfeeding, poor weaning, and immunization history, should be referred for prompt ophthalmological review due to risk of permanent visual loss. On conclusion, vitamin A deficiency is a preventable yet leading cause of blindness. Unawareness and ignorance of the general population has to be addressed at an urgent basis, and prompt referral along with door-to-door immunization and vitamin A supplementation by primary healthcare and social workers should be encouraged. These are my references.